Hello, everyone. Today we are going to discuss the Phase 3 changes in pharmacy services. So let's begin. Just remember, this presentation are for general information and do not include a full analysis of any specific circumstances or situations. Information contained herein is accurate at the time of publication of the State Operational Manual dated February 2023. Today's learning agenda include a discussion of the following topics. First, overview of key regulatory changes. Second, key changes to F755, pharmacy services, and third agenda will discuss changes to F758 use of unnecessary psychotropic drugs and its as-needed usage. Followed by the fourth discussion of the 4 distinct steps in discontinuing medications and fifth adverse drug withdrawal events. Today's learning objectives will include participant having to understand how to correctly dispose of pharmaceuticals, understand the signs of unnecessary antibiotic use that may indicate inadequacy of the antibiotic stewardship program, understand what categorizes a drug as a psychotropic medication, understand how to correctly diagnose patients for use of antipsychotics and keep track of the potential side effects, and understand how to correctly wean patients from their medication. Let's begin learning. There are 3 major regulatory changes in pharmacy services. The first change is under F755, which clarifies the language regarding the disposal of fentanyl patches. The second change is under F757, related to drug regimen reviews, ensuring freedom from the use of unnecessary drugs. Key changes here include languages related to the antimicrobial stewardship program and references to F881. The third change is under F758, which addresses the use of unnecessary psychotropic medication and PRN as needed use. In this regulatory category, there have been clarifications about other classes of drugs not previously listed in the regulations and how they are affected by psychotropic medication requirements. The regulation also includes language on potential misdiagnoses, such as schizophrenia, when such psychotropic medications are prescribed. All 3 pharmacy services regulatory changes are considered significant at the time of release for Phase 3. Now, let's look at the different pharmacy services regulatory changes one by one. Let's begin with F755 under pharmacy services. F755 deals with the proper disposal of pharmaceuticals. Clarifications have been rolled to help clarify the disposal of fentanyl patches. So let's look at the revised guidance. What is the revised guidance saying on disposal of fentanyl patches that have been used? The Food and Drug Administration instructions to fold-use patch and flush-down toilet are not always appropriate for nursing homes. The Environmental Protection Agency does not currently ban flushing of pharmaceuticals, unless considered hazardous. However, fentanyl patches are not classified as hazardous, but state and local laws may restrict flushing of pharmaceuticals. Nursing homes may use drug disposal systems if they can show the system minimizes accidental exposure and diversion. Disposal of fentanyl patches in common areas or room trash cans or sharps containers would not be compliant as these methods do not prevent accidental exposure or diversion. Now, let's look at the second regulatory changes under the pharmacy services groupings. F757, which includes drug regimen review, added language related to antibiotic stewardship program. Additional notes have been added to F757 and F758 to lead surveyors to scrutinize F881, the tag for the antibiotic stewardship program. So now let's look at the revised guidance on drug regimen review. Before we begin looking into the changes, let's look at definition changes that have been updated in the regulation. The revised guidance provided additional notes and languages. These have been added to F757 and F758 to lead surveyors to scrutinize F881, the tag for the antibiotic stewardship program. Any negligence in antibiotic usage, such as the unnecessary use of antibiotics, may result in issues related to F881 compliance. Further scrutiny will be placed on looking at whether the unnecessary antibiotic use could indicate that a facility is not implementing part or all of an antibiotic stewardship program, which entails using protocols which include using an infection assessment tool, monitoring of antibiotic use, and feedback or education to prescribing providers. Now, Let's look at the last regulatory changes under the pharmacy services groupings. In November 2017, the regulations and guidance expanded the category of antipsychotic medications to psychotropic medications, which includes antipsychotics, antidepressants, anti-anxiety drugs, hypnotics, to address the concern that use of other psychotropic medications may increase as nursing homes attempt to decrease antipsychotic use. The guidance also describes other medications which affect brain activity, may be clinically indicated, but can also have adverse consequences. So let's look at definition changes contained in the current guidance. First, let's look at dose. Dose is the total amount, strength, or concentration of a medication given at one time or over a period of time. The individual dose is the amount, strength, or concentration received at each administration. The amount received over a 24-hour period may be referred to as the daily dose. Next, let's look at duplicate therapy. Duplicate therapy refers to multiple medications of the same pharmacological class or category, or any medication therapy that substantially duplicates a particular effect of another medication that the individual is taking. The last definition change applies to excessive dose. Excessive dose means the total amount of any medication, including duplicate therapy, given at one time or over a period of time that is greater than the amount recommended by the manufacturer's label, package insert, and accepted standards of practice for a resident's age and condition. Language was added to the gradual dose reduction, GDR section. Dose reductions should occur in modest increments over adequate periods of time to minimize withdrawal symptoms and to monitor symptom recurrence. Compliance with the requirement to perform a GDR may be met if, for example, within the first year in which a resident is admitted on a psychotropic medication, or after the prescribing practitioner has initiated a psychotropic medication, a facility attempts a GDR in 2 separate quarters, with at least 1 month between the attempts, unless clinically contraindicated. Resources for gradual dose reduction information were added, such as 1. The American Psychiatric Association practice guidelines on the use of antipsychotics to treat agitation or psychosis in patients with dementia, published in 2016, and 2. Discontinuing medications, a novel approach for revising the prescribing stage of the medication use process, published in 2008. The links to both resources are available in the handout section of this presentation. The use of these other medications is subject to the psychotropic medication requirements if documented use appears to be a substitution for another psychotropic medication rather than for the original or approved indication. For example, a seizure medication is being given to a resident with no history of seizures, but the medical record shows the medication is given to treat agitation. The use of the seizure medication should be consistent with the psychotropic medication guidelines. Another change in the regulation is to look at current practice in how schizophrenia as a diagnosis is being used. To avoid potential misdiagnosis of residents, added language about the potential misdiagnosis of residents with a condition for which antipsychotics are an approved use, such as using a new diagnosis of schizophrenia, which excludes the resident from the long-stay antipsychotic quality measure. Further, this potential misdiagnosis issue can lead surveyors in considering and investigating under F658 to determine if the practitioner's diagnosing practices meet professional standards. Next, the regulation also added language that any potential misdiagnosis issue can lead surveyors in considering and investigating not only under F658, but also to look under F641 to determine if the facility completed an assessment which accurately reflects the resident's status. Another updated language in this pharmacy services includes psychosocial harm. Recent updates include language that directs surveyors to evaluate whether a resident experienced psychosocial harm related to medication side effects. This evaluation is critical in assessing the comprehensive impact of medications on a resident's well-being. Did side effects such as sedation, lethargy, agitation, mental status changes, or behavior changes affect a resident's ability to perform activities of daily living or interact with others? Cause the resident to withdraw or decline from usual social patterns? Result in the resident showing decreased engagement in activities? Lead to diminished ability to think or concentrate? These assessments aim to ensure that any negative psychosocial impact is identified and addressed promptly. Surveyors will use these criteria to categorize deficiencies more accurately, ensuring a higher standard of care and attention to the holistic needs of residents. This approach emphasizes the importance of monitoring and mitigating adverse effects to maintain residents' quality of life and social engagement. The medication use process traditionally includes 5 stages: prescribing, communicating orders, dispensing, administering, and monitoring. Preventable adverse drug reactions, ADRs, most often occur at the prescribing stage in both acute and ambulatory care settings. Various approaches, such as pharmacist-conducted drug regimen reviews and computerized physician order entry or electronic prescribing, have been evaluated to improve this stage. However, these approaches often have a narrow focus, targeting issues like underprescribing, medication choice, or dosage. Prescribing should not occur in isolation, but must integrate both the processes of prescribing and deprescribing or discontinuing medications. Assessing the potential for rationally discontinuing medications is essential to enhance prescribing practices and prevent ADRs. Evidence suggests that discontinuing specific medications in certain patient populations does not worsen outcomes, decreases the risk of ADRs, and reduces medication costs. Thus, integrating strategies to improve medication discontinuation into the healthcare system must be prioritized. The steps associated with starting or changing a medication regimen are well documented, but clinicians must also consider discontinuing medications when appropriate. This may occur when initiating a new medication, changing the drug regimen, or addressing drug-drug interactions. Therefore, prescribing and discontinuing medications are iterative processes that can involve multiple cycles of evaluation and decision-making. The medication use process has been revised to enhance the prescribing stage by explicitly including the discontinuation of medications. This change aims to ensure a more holistic approach to medication management, where the need to stop a medication is considered as important as initiating one. By integrating discontinuation into the prescribing stage, healthcare providers are encouraged to regularly review and assess the necessity of ongoing treatments, reducing the risk of polypharmacy and potential adverse effects. This revision emphasizes the importance of monitoring patient outcomes and making informed decisions to discontinue medications when they are no longer needed or beneficial, thereby improving overall patient care and safety. Discontinuing medications involves 4 distinct steps. First, recognize an indication for discontinuing a medication, such as adverse effects or lack of clinical improvement. Second, identify and prioritize the medications to be targeted for discontinuation based on their impact and necessity. Third, discontinue the medication with proper planning, ensuring clear communication and coordination with the patient and other clinicians involved in the patient's care. And finally, monitor the patient closely for any beneficial or harmful effects following the discontinuation to ensure optimal outcomes and address any issues promptly. Medications frequently associated with adverse drug withdrawal events, ADWAEs, include those from the cardiovascular and central nervous system drug classes. Within the cardiovascular category, beta blockers are commonly linked to ADWEEs, primarily due to physiological withdrawal reactions or exacerbations of the underlying condition. Similarly, within the central nervous system category, benzodiazepines are often involved in ADWEs, with withdrawal reactions such as anxiety that can mimic the underlying condition. To minimize the risk of ADWEs, it is advisable to taper many medications gradually over days to weeks, especially those used long-term. The best tapering rate cannot be predicted solely by pharmacokinetics, as medications may alter receptor binding and post-receptor activity, which depends on factors such as binding affinity, receptor activation, dose, and duration of use. For example, prolonged use of high-dose steroids can suppress the hypothalamic pituitary adrenal (HPA) axis, but the duration of therapy and cumulative dose only roughly predict this suppression. Since the optimal dosage reduction methods for steroids are not well defined, patients on long-term systemic steroid therapy should have their doses tapered slowly over weeks. This approach highlights the importance of considering pharmacokinetics, pharmacodynamics, dose, and duration when discontinuing medications. Moreover, it is generally recommended to discontinue medications sequentially rather than concurrently to clearly attribute any withdrawal events to the specific medication ceased. Studies consistently show that with these principles, most medications can be discontinued safely and effectively without causing ADWEs. The revised guidance on drug regimens emphasizes the importance of proper medication management, particularly for psychotropic medications. It highlights the need for careful assessment and documentation to ensure that medications are prescribed appropriately and only when necessary. This includes a thorough evaluation of the patient's condition, ongoing monitoring of the medication's effectiveness, and vigilant observation for any adverse effects. Regarding psychotropic medications, the guidance underscores the significance of avoiding unnecessary prescriptions and considering non-pharmacological interventions when possible. It also calls for regular reviews of the patient's medication regimen to determine if any psychotropic medications can be reduced or discontinued safely. To minimize the risk of adverse drug withdrawal events, ADWEs, it is crucial to taper medications gradually, especially those used long-term. The tapering process should take into account pharmacokinetics, pharmacodynamics, dose, and duration of use, recognizing that the optimal rate of taper cannot be predicted by pharmacokinetics alone. That concludes our pharmacy review today.